Okay, second and good day to all students. For this topic, we're going to discuss on the defecation, the compositions of the feces, vomiting, diarrhea, and constipation. All right. So at the end of these lectures, students should be able to describe the reflex of defecations and feces compositions, to describe the abnormal conditions of the digestion process, which are the diarrhea, the vomiting, and constipation. Yeah, in this topic. All right. So in previous, we have learned on the colon absorptions and the motility. So for the final process in the gastrointestinal system is the defecation. Okay. So like urination, the elimination of feces is not a continual event but is episodic and is controlled by the neurological reflexes and sphincter. So we can say that it occurs only appropriate circumstances and times. So what is defecation? It's the act or process by which solid or semi-solid waste materials, remember it's already most of the water has been absorbed in the colon to convert it into these feces, okay, from the digestive tract are eliminated through the anus. So the rectum ampulla is the place to temporary storage for this waste. So as the rectal wall expands, okay, the stretch receptors from the nervous systems located in the rectal walls stimulate the desire for you to defecate. Okay. So what are the defecation reflexes? So we have two. The intrinsic defecation reflex and also the parasympathetic defecation reflex. Okay, let's look in the intrinsic defecation reflex. So the stimulus is the feces enter the rectum. Okay, for both is same. Okay, distension of rectal wall, and then the receptors is the stretch receptors in the rectal wall. However, the difference starts in the afferents, okay, where in the intrinsic is the sensory fibers terminating in mandric plexus to the mandric plexus, back to the motor signals to smooth muscles, okay, and then it goes, which is involved of the smooth muscle cells of descending sigmoid colon and rectum, and where it will cause the muscular contractions that force the feces towards rectums, okay, by the relaxations of the internal uh, anal sphincter, okay, IAS. For the parasympathetic, the afferent is the sensory fibers that terminating in S2 to S4 cord level. Okay, the centers is this S2, S4 spinal cord segments. Okay, the efferents is the pelvic parasympathetic nerve. The effectors is the smooth muscle cells of descending sigmoid colon and rectum, where it produces the same response. Okay, the muscular contractions that forcing feces towards the rectum, where the relaxations of the internal anal sphincter. So what we can say here is the control of anus is by constrictions of the internal anal sphincter and external anal sphincter. Okay, so what's the difference? So this internal anal sphincter is the one that thickening circular smooth muscles that immediately inside the anus. So it means it's involuntary. You cannot control it. Okay, so the sympathetic were excitatory, the parasympathetic is the inhibitory. So the external anal sphincter is the striated voluntary muscles that surrounds the internal anal sphincter, and this is the voluntary. Okay, means you still can control at one point. So what are the defecations? Okay, how the process happen? So in during defecation, what happens is there is a triggered by stretching of the wall, okay, mediated by spinal cord parasympathetic reflex. So it stimulates contractions of smooth muscles in the wall and relaxations of the internal anal sphincter. So these relaxations of the internal anal sphincter causes a signal to be sent to brain indicating urge to defecate. And if convenient to defecate voluntary, motor neurons will stimulate relaxations of external anal sphincter. Okay, this is helped by the diaphragm and abdominal wall muscles called the Valsalva maneuver. Okay, so what we know here is that the internal anal sphincter is usually tonically contracted. But then when the amounts of feces or materials exceeds around 500 ml, the internal anal sphincter will relax. Okay, and the contents will move to the anus. So at that time, you will feel urgency of defecation, but you're still able to control. Okay, this control is due to the contractions of this external anal sphincter and pivorectalis muscles that are relaxed. So now we're going to look on the conditions, whether is it okay to defecate or no, or is that no place is not suitable to defecate yet. So if your surrounding circumstances are suitable for defecations, so the defecation reflex will be allowed, where the stretch of the rectal wall is signaled to the spinal cord by pelvic nerve. The efferent pelvic impulse will cause reflex contractions of the rectum and relaxations of the internal anal sphincter. This is followed by the reductions in tonic impulse to external anal sphincter. So it relaxes voluntarily and feces leave the rectum, assisted by the voluntary straining and contractions of these pelvic floor muscles. Okay, let's say if the surrounding is not suitable. Okay, if suddenly you are outside and you can't find a toilet or place that you can defecate. So what will happen is the reflex can be inhibited by the cerebral cortex, where it maintains the voluntary tonic contractions of the external anal sphincter. So this will return the tonic contractions of the internal anal sphincter and accommodations of the rectum to the distension. Okay, so this is the process, whether suitable or not suitable, and how it can control, okay, the defecation. So now we're going to look at the compositions of the feces. So what's inside your feces in the normal healthy feces? So first, of course, most of it is water. Okay, around 65 to 85% of stools are water. Okay, so examples like all the water that drank by individual is completely absorbed in the small and large intestine. Okay, in case of the diarrhea, the water contents of stool is more than 85%. Okay, but use. And then second is the protein. Okay, where this protein came from the undigested dietary protein and protein from the bacteria itself. What else? You have fat in that. So 95% of all fat consumed is absorbed in the small intestine, but traces of fat can definitely be found in the stools, okay, in the small portions. But then, however, if the fat contents in the stools are more than 6% of the normal value, so we call this abnormal, okay, or known as the steatorrhea. Okay, other than fat, we also have the carbohydrates in the feces. Okay, simple and complex carbohydrate means that the sugar and starches in the diet. So they are completely absorbed in the small intestine and assimilated in the blood as the glucose, fructose, or galactose. So all these the undigested carbohydrates in normal stool should be below of 0.5%. Okay, this is common fiber. So fiber is completely indigestible and give the volume and bulk to the stools. So the more fibers the persons ate, the more of undigested food waste can be discharged from the body. Okay, so otherwise the undigested food remnants may be left behind, and this will be a problem. Okay, because it cannot digest and then it's stuck there. So it's not good. So with a low fiber diet, the undigested food will account for 5 to 7% of the total stool volume. With a high fiber diet, 10 to 15% of the undigested waste could be discharged from the body. What are the other components? Okay, it also contains the mineral salts, which are insoluble. Okay, they too cannot be digested by the body. This indigestible component of feces is known as ash, where around 0.2 to 1.2% of normal stool is ash. So the stools also contain mucus that shed from the inner lining of the digestive tract, where this mucus helps to bind together the undigested food, the intestinal bacteria, and metabolic debris like dead cells or uh, by bile secreted by the liver. So that's all the compositions of the feces. So now let's look at the problems, okay, related to this defecation or abnormality. Okay, so I'm sure all of you has experienced this diarrhea. So what is this diarrhea? So diarrhea is defined as the passage of 3 or more loose stools per day, or passing more stools than normal for that age. Okay, that particular age. So increase of the stool volume, okay, usually to more than the 200 ml per for 24 hours. And then you can see there is an altered stool consistency, means there is increase of the liquidity of the stool. So how many types of the diarrhea? So pathophysiologically, we can divide it into osmotic diarrhea, secretory diarrhea, the motility-related, and exudative diarrhea. So of course, more than one of these mechanisms can be involved in the pathogenesis of a given case. Okay, it can be a combination of this diarrhea. Before we proceed with the specific of the types of diarrhea, you need to understand first on the fecal osmolarity. Okay, so as a stool leaves the colon, the fecal osmolality is equal to the serum osmolality around 290. So under the normal circumstances, the major osmoles are sodium, potassium, chloride, and bicarbonate ion. Okay, So we know it's a 290, and then this is the major osmoles that contribute to it. Okay, so let's look at first type, the secretory diarrhea. So I see here the secretory diarrhea results from the abnormal ion transports in intestinal epithelial cells. Okay, where there is excess input of these electrolytes, the sodium chloride, and increase in the active secretions of water. Okay, so as you see in these pictures, okay, there is a problem of excess input of electrolyte, the sodium chloride, with water following. Yeah, that's why you have increase in the active secretions of the water. So this diarrhea is persists during the fasting, and the stool osmotic gap is very low. Okay, and it is isotonic. What is the most common cause is due to the bacterial toxin, okay, the E. coli, that stimulates the secretions of anions. Okay, so that is the secretory diarrhea. The next type is the osmotic diarrhea. Results from excess amount of poorly absorbed substance that exert the osmotic effect, where water is drawn into the bowels that leads to, of course, diarrhea. So it can be watery or loose, okay, but then this diarrhea stops when the patient is fasting. Okay, the stool analysis which shows the osmotic gap more than 125. It can be results of the malabsorptions, okay, in which the nutrients are left in the lumen to pull all the water. Okay, examples in the lactose lactose intolerance, and also the osmotic laxative. Okay, the next one is the deranged motility. Okay, so hypermotility. Motility we know is a movement, right? So means hyper means it's a rapid movement of the food through the intestine. Okay, where it decreases the contact time of the stool to the absorptive surface. So you know intestine is work to absorb. Okay, in the small intestine is to absorb the nutrients. The colon is to absorb the water. Then if there is a rapid movement, okay, there's no time to do all these absorptive actions. So so many so you have lack of the absorptions there. Okay, so abnormally how about if slow motility? Abnormally slow motility may result in bacterial overgrowth and resultant diarrhea. Okay, let's look on the rapid just now. The rapid intestinal motility, it may result in diarrhea again due to the reduced contact time between luminal contents and the bowel mucosa. Okay, the examples includes when the persons have anxiety, hyperthyroidism, IBS, okay, this post-vagotomy diarrhea, and the viral gastroenteritis. Okay, um, it's occur with stress and neurological disorder. Okay, and diagnosed by exclusions of bacteria, viral infections, and malabsorption. So this type you will usually see, especially when you having exams, so students having going to have the exam and they start to have this enhanced rapid, enhanced motility. Okay, this kind of diarrhea causes stress. So the fourth one is the exudative diarrhea, which results from the disruptions of the intestinal mucosa from inflammation or the ulceration. It can be from the several mechanisms, either through the stimulated secretions and inhibited absorptions, or stimulation of enteric nerve that cause propulsive contractions and stimulated secretion, mucosal destruction and increased sperm mobility, and also maybe could do from the nutrient maldigestions, malabsorptions. So basically, you will see the blood, mucus, and serum proteins in the gut ferments. Okay, and then so all of these are the types of diarrhea. So so what happened in constipation? Okay, just now you have diarrhea, and how about if you're having constipation? What is this? How different is this with diarrhea? So this constipation defined as the infrequent passage of stool, less or equals to 3 bowel movement per weekend, not per day, per week, associated with straining to defecate, where the passage of hard stools, the tenesmus, or the need for the self-digitation to evacuate the stool. Okay, so there are two types of constipation. We have primary constipation, secondary constipation. Okay, so for primary constipation is no identifiable organic cause. Includes the normal transit constipation. Means what does it mean? Normal transit, a slow transit. Okay, due to the inadequate calorie, fiber, or water intake. Okay, or it could be due to the slow transit constipation. Okay, slow means it's reduce the motility of the large intestine. Maybe it's due to the abnormality of enteric nerve. So we know that the enteric nerve is for the motility. So if there is abnormal there, maybe it can cause the reduce the motility. So once it's reduced motility, what happen? It will stay in the maybe in the intestine for a longer time. So again, it's contradict with the diarrhea just now. If you stay there too long, means it will expose for exhaustion for a long time. Okay. And then also for pelvic floor dysnergia, okay, where the pelvic floor become uncoordinated. So this make it difficult to have a bowel movement. Okay, so the secondary constipation it can be due to the drug induced, okay, the opioid induced constipation. Okay, this opioid is activating the enteric opioid receptor, where it decreases the bowel tone and contractility, so which will increase the colonic quick absorptions and anal sphincter tone while reducing the rectal sensation. That's why it leads to the harder stools, which can be difficult to pass. Or this could be due to the metabolic disorder, examples like the hypothyroidism. Okay, hypothyroidism, it can slow down the body functions, including the bowels. Or could be due to the neurological disorder, examples like the spinal cord lesion. Okay, and then because the spinal cord lesions, it related to the sphincters control, muscles of the sphincter. And then the off could be due to the mechanical obstructions of the bowel. Well, one of it is colon cancer, okay, where it causes the obstructions there. So it falls under the secondary constipation. So the next abnormality is the vomiting. Okay, so vomiting is reflex, a complex reflex. Okay, it looks easy to vomit, but actually it's a very complex reflex where there is involuntary, forceful, and rapid expulsion of the gastric contents from your tummy, from your stomach contents through the mouth. So its role is to protect the body from ingested toxins by expelling them from the body. Okay, so how this process of vomiting happen? So we have three phases there, sorry. Pre-ejections, retching, and ejections. Okay, in the pre-ejection phase, the stomachs and pyloric sphincter will relax, and then there is a reversal peristalsis. So it reverses backwards, okay, to empty the material. It can be from the small intestine into the stomach. Okay, and then what happened? The retching, where there is a rhythmic actions of the respiratory muscles preceding the vomiting and consists of these abdominal and intercostal muscles and this diaphragm against closed glottis. So final step is the ejections, when there is an intense contractions of the abdominal muscles and relaxations of both the lower and upper esophagus sphincter. So there is a rapid and forceful expulsion of gastric contents into the esophagus, okay, and out through the mouth. Okay, so from intestines to the stomachs, pass through all these lower and upper esophagus sphincter, expel to the mouth. Okay, so what are the control of the vomiting? So two main regions are implicated in the vomiting reflex: the vomiting center and the chemoreceptor trigger zone, or known as CTZ. And also the activation of either regions leads to the vomiting. Sorry for the spelling. Okay, so let's see how complex is this vomiting. So this shows the figures of the overall pathway and stimuli that induce the vomiting. Okay, first we know there is the vomiting center. Okay, vomiting center that located in the dorsal part of the lateral reticular formations of medulla, where it receives various afferent inputs and then it integrates them and then initiates the motor efference output to skeletal and visceral smooth muscles if vomiting is to be initiated. So how is this vomiting center is activated? It is activated by where direct stimulation. Okay. Uh, sorry. Okay, it's a direct stimulation. Okay, where there is a if you look at the first two boxes, okay, the direct stimulation. Examples when there is an increase of intracranial pressure will cause the direct injury to the area. Okay, so the nucleus tractus solitarius, okay, will receive inputs from the stretch chemoreceptors in gastric and duodenal mucosa, which stimulated by local irritation and will send the afferent signals through the vagal and SNS nerve. Okay, the touch receptors in the uh, pharynx was stimulated by the touch, was sent through this afferent signals through this cranial nerve. Okay, so we also have the from the afferent input, okay, from the vestibular nuclei. Okay, vestibular nucleus. Okay, where from vestibular apparatus due to the motion sickness or dizziness. Okay, and you also have these cerebral cortex and limbic systems. Okay, this is more to emotionally charged stimuli, as you can see in example here. Okay, maybe due to the sickening sights, the fear, okay, the anticipation. All this is psychological factors. Okay, so in the event of the vomiting, the vomiting center will send the efferents output to the upper GI tract, okay, and also to muscles of diaphragm and abdominal muscles through the spinal nerve. So just now I mentioned we have the CTZ, okay, the chemoreceptor trigger zone. Okay, so this is located in the area postrema, okay, floor of the fourth ventricles outside the blood-brain barrier. So it is activated by, as you can see here, the circulating drugs or toxins, okay, in the blood, by the vestibular nucleus, okay, and also by the stretch and chemoreceptors in gastric and duodenal mucosa. So this is the overall pathway and stimuli that inducing the vomiting, which involve the vomiting center and also the CTZ. So what will happen if you have the prolonged vomiting? Okay, what will happen? So first, you need to understand this. Um, what is the conditions of the gastric juice? So gastric juice is, we know, is very acidic. So it's an acidic fluid which rich in the hydrogen ion, chloride ion, and potassium ion. And it's very poor in the sodium ion. Okay, be clear about this. So now, if there is a prolonged vomiting of this gastric juice, okay, because we know it's a it's a reverse peristalsis, right, from this gastric from the stomach's contents, okay, intestinal to stomach and then out. So prolonged vomiting of this gastric juice, okay, examples like the pyloric stenosis, it will cause first hypovolemia. Why? Because direct loss of fluid in the vomitus. Second, the electrolyte imbalance, okay, where it causes the hyponatremia, okay, hypochloremia, and hypokalemia, because you loss of this gastric juice in the vomitus. Okay, so third is the metabolic alkalosis. Why metabolic alkalosis? Because you lost, okay, in vomiting, prolonged vomiting, we will loss of gastric acid in the vomitus, and of course, it will lead to, it will cause the malnutrition, okay, because you lost all of these nutrition, okay, it's not absorbed because it's been pushed out back through the out from the mouth. Okay, so that's all about this topic. So we learned about the defecation reflex. Okay, in the situation whether it's suitable or not suitable to defecate. Okay, and then we know the normal compositions of the feces, and then we look on the types of diarrhea, some of the causes of this diarrhea. There are lots, but I just highlight some of it. And then the constipations, and also the complex mechanisms of the vomiting and the consequences of the prolonged vomiting. So that's all for this topic, and thank you.